We're going to talk about physical exam and pertinent clinical pearls for the diagnosis of peripheral arterial disease. This is the student edition. So how many people here are in the first year? And how many in the second year? And the third year? All right. So the people in the second year haven't had Dr. Schwartz's class yet, no? You have, so you're going into it now. So technically, you've started it. Okay. So a lot of what we'll talk about will be pertinent to what you'll be doing, and for the people in the third year, it'll be a review, and the people in the first year, it'll be something that you'll be doing next year. But I tried to make it as germane as possible to what we're going to do. I have nothing to disclose. Sadly, no financial relationships, and as they say, I work at the college full time. I get paid weekly, very, very, very weekly. So the talk is about doing a physical examination, but before you do the physical, as people who've had Dr. Schwartz's physical assessment course already have learned, and the people who are about to have it will learn, the history is a very, very important part of any examination, and sometimes it's just as important as doing the physical exam. And I think one of the pearls that I want to give you is first you need to rule out the worst. What's the worst case scenario? Is it something that's acute that needs to go to the OR immediately, that needs to be admitted that day, or is it something that's chronic, slowly progressive, and it's urgent, but it's not emergent? So we need to remember that we need to rule out things like critical limb ischemia and thromboembolic events, something that's acute, something that needs intervention immediately, versus something that you have a little bit more time with. So like in fishing, it's all in the presentation. And your diagnosis is made largely on the basis of the history that you get from your patient, and then your physical exam confirms or rules out your suspicions. So history is just as important as the physical exam. So what lower extremity symptoms that patients will present to you with will raise a red flag in terms of them having peripheral arterial disease in general, and something that we need to follow up on with a vascular consult and further non-invasive or invasive testing. Patients with pain or cramping or sense of heaviness or fatigue in the lower extremities, color changes in the feet or the toes. And if that's the case, then you follow up with pertinent questions such as, is it unilateral or bilateral? Is it intermittent or constant or progressive? What makes it better or worse? And probably one of the most important questions that you could ask, is it of gradual onset or was it of sudden onset? And one thing you'll learn when you deal with patients with peripheral arterial disease is that end-stage ischemic rest pain is refractory to pain medication. It's constant, it's boring, it's gnawing, and it's unrelieved by analgesics. So Dr. Schwartz is going to teach you, if he hasn't already, that the physical examination proceeds in an orderly fashion. After you do the history, it proceeds in the fashion of IPPA, inspection, palpation, percussion, and auscultation. In the case of examining the abdomen, it's an inspection, auscultation, palpation, and percussion, but it's an orderly fashion, essentially so you don't forget anything. So I think what we are going to be looking at today in terms of peripheral arterial disease, lower extremity arterial exam, is inspection, palpation, and auscultation. And our inspection starts when you first enter the exam room. And it's a really good opportunity to see the patient with their limbs in a dependent position. They've been sitting in the waiting room, they've walked from the waiting room to the exam room, and now they're sitting in the chair, taking their shoes and socks off, and their feet and legs are in a dependent position. And this is the time that you want to examine for color change, dependent rubor. You want to compare one lower extremity to the other, one foot to the other, one toe to the other. And as the patient sits in the exam chair, that's your opportunity to stand behind the patient and sort of get an overall view, a better overall perspective of their lower extremities. And I'll show you what I mean by that in a second. So, for example, if I showed you this picture and I asked you to comment on the color of that foot, is it normal or is it abnormal? Just by itself, it probably wouldn't impress you too much. And then I would say, well, how about the opposite foot? And just by itself, you know, it probably wouldn't be too impressive. But when I compared one foot to the other, then we can start to see that in the patient's right foot, so that's your left, so my right as I'm looking at it here, the patient's right foot, you can see a little bit of a dependent rubor. And under incandescent light, that's brought out a little bit more. So you have some dependent rubor on the right foot versus the left foot. Now, as the patient sits back up in the chair and the legs are brought up level with the rest of the body, you can now see that the right foot is a little bit paler than the left. It's very, very subtle. And sometimes comparing one lower extremity to the other brings out this very subtle color change. So you have dependent rubor, right, with the right foot a little bit more rubrous than the left. And then when the patient brings both legs up, you can see that there's a little bit of a little pallor and elevation of the right foot. And then as you look over the patient's shoulder, if you go back into behind the chair, where you can get sort of a long-range view, you can see again the right foot has a little bit more pallor to it, a little bit different color change than in the opposite foot. And we're going to inspect the skin. So inspection, palpation, and auscultation. So now we're up to inspection. We're going to inspect for skin color. Is the skin color dark or dusky? Is the texture of the skin shiny and atrophic, or is it supple and well hydrated? Is there digital hair? Is the digital hair present or is it absent? Are the nails dystrophic? Do they look mycotic, but they're really not mycotic? They're dystrophic not because of a mycotic skin infection, but because of the effect that the peripheral arterial disease has on the nail matrix and the growth of the nail. Is there rubor on dependency and pallor on elevation? And are there any open wounds? And when we look at the open wounds, we can get a good sense of the peripheral arterial disease with the quality of the wound. Is it a good red granulation tissue base, or are there areas of necrosis in the wound? This is a little bit more robust color difference between one limb and the other, and the patient's right limb, as we can see compared to the left, has some significant rubor on dependency. Now look at the nails. Look at the nails of the patient's right foot compared to the left. The nails are dystrophic as opposed to the left foot. The skin is shiny, it's atrophic, and as we now look a little bit further away and get a better perspective, we can see that the rubor is not just confined to the forefoot, but then goes all the way up to the midfoot or the ankle compared to the opposite foot. And now the patient's right foot, looking from behind the patient, we can see there's some shininess to the toes, some edema. And again, we can tell that this process is much more proximal than you might have initially appreciated. It involves the midfoot and goes up to the level of the ankle and probably beyond. Well, this is obvious peripheral arterial disease. It's beginning to demarcate, and if you could look at the quality of the skin proximal to the line of demarcation, you can see the skin is very tight. It's bound down, and we can see that the patient has some dependent rubor as well, distinct from what we like to see. And this is a normal foot. This is the foot of one of our students, a young, healthy male. Yes, well, I don't want to give anything away as who this was, but. This is what we like to see, right? Good color, good texture, skin is supple, well hydrated, digital hair growth, and all the color of all the toes are normal, and the nails are all normal. So this is the ideal. But this is a young, healthy male student that we have. So let's look at the wound bed. So if I asked you the question is, which one of these wounds do you think has the best healing potential? What would you say? None of them are really great, right? You don't want to have any of these wounds yourself. But if I had to say which one had the best potential for healing, what would you say? The one all the way on the right? So it's intuitive. And why is it the one on the right? Because it has good red granulation tissue base, some fibrotic tissue. But why not the one on the left? Right? The one on the left has, right, some necrotic tissue, islands of necrotic tissue. This is, by the way, is a partial first and second ray amputation. Right? So it was left open, so-called guillotine amputation. But look in the center, we have that island of necrotic tissue, and look at the borders of that wound, some necrotic tissue around the borders. Doesn't really bode well for healing. And look at in the center, right? You know what you should have when the nail is avulsed? You should have a nice red, beefy granulation tissue base, as if I avulsed the nail of anyone in here. But this is not healthy. This is the sign of a patient with peripheral arterial disease, with a gray fibrotic base, with a little island of necrotic tissue right in the center. And look at the skin. The skin is shiny, it's atrophic, and it's dysvascular in appearance. How about these two wounds? So which do you think has better healing potential, the one on the right or the one on your left? Yeah, the one on your left. Actually, we saw this patient in Metropolitan Hospital, and the reason why they have this wound is because there was a plantar space infection that we IND'd in the emergency room and went on to have a first and second ray amputation. And this closed now. We're still seeing that patient, but without any vascular intervention. The patient had good peripheral circulation. The patient on the right, on the other hand, we also saw at Metropolitan Hospital. and we had asked Dr. Krishnan to intervene on this patient's behalf. But we asked him to intervene because it had all the signs of something that's not good, that has very poor potential for healing. Instead of a red granulation tissue base to that second toe amputation site, which was amputated because of gangrene of the second toe, we can see it's yellow, it's fibrotic, there's no granulation tissue. You can see on the dorsum of the foot that we're starting to have a necrotic patch, a gangrenous patch on the top of the foot. And on the right second toe, you can see on the medial aspect of the right second toe, we can see a patch of gangrene. If you compare the color of the second toe to the third toe, we can see it's starting to become a little dusky. And these are really bad prognostic signs. So now let's look more at the hands-on physical exam, and we're going to look at the temperature gradient from the knees to the toes. Should be warm to cool, approximately a 10-degree temperature difference between the knees to the toes. The capillary filling time, 2 to 3 seconds, and I'll explain all this in a second. And then, of course, the pedal pulses, and we're looking for the ideal strong, equal, and regular. Well, this is a temperature gradient, right? Temperature gradient, for those who don't know, you take the back of your hand and you run it down from the knee all the way down the anterior aspect of the foot, all the way to the toes. You're looking for a normal temperature gradient of warm to cool. A temperature gradient that's reversed, it would be warm to warmer, right? So it would be warm, it would be reversed. And an increased temperature gradient, it wouldn't be warm to cool, it would be warm to cold. So that'd be an increased temperature gradient. So let's hope this plays here. This is how we do a temperature gradient. And at the end, what I do is I just gently grasp the toes, and I can appreciate the temperature of the toes of either foot, and I compare them. Right? This is capillary return. So essentially, you take your finger, you press it in gently into the toe until it blanches, and you estimate how many seconds it takes for the color to return. So this would be how we perform a capillary refill test, or capillary return. Normal is about 2 to 3 seconds. Delayed would be indicative or suggestive of peripheral arterial disease. And I just did it to one toe here, but you would do it to each toe of either foot. Femoral pulse, palpate the femoral pulse. Sometimes I'll use 8 fingers. I'll use 4 fingers of each hand. Put all 8 fingers right in the inguinal crease to give myself the best chance of being able to palpate the femoral pulse on the first go. Femoral pulses are very easy to feel. Femoral arteries may be about the thickness or maybe a little bit thicker than the tubing of your stethoscope. It's relatively superficial. It's a very easy to feel bounding pulse when it's palpable. Popliteal pulses, even when you do it right, sometimes they're very, very difficult to palpate because they're deeper than the femoral pulse, and they're in the popliteal fossa. Sometimes you have fat in the popliteal fossa. So they're not it's not as discrete as a femoral pulse. Again, difficult to feel even when you're doing it right. Posterior tibial pulse, now we have both hands. We can compare left to right at the same time. And it's right behind the medial malleolus. And the dorsalis pedis, right? So you send out 3 fingers of each hand, put them across the dorsal aspect of each foot. So each finger has an equal chance of finding that dorsalis pedis on the first run. And dorsalis pedis ideally is between the extensor hallucis longus and the extensor digitorum longus. And all the time you're doing that, you're appreciating, again, the color of the skin. You're comparing one toe to the other. You're comparing one foot to the other, looking for the presence or absence of digital hair growth. So there are various, if you read the literature and you look at different textbooks, there are various grading scales of peripheral pulses. So this is just one grading scale, Clinical Methods, 3rd edition by Walker et al. 0 to non-palpable, 4+ bounding, where 2+ is slightly more diminished than normal. And a lot of mention is made of quote-unquote normal, what are normal pulses, but to somebody who hasn't palpated a lot of pulses, what is normal? So it's sort of subjective, right? If you're a student, you've never palpated a pulse before, the very first pulse you palpate, you have no frame of reference as to whether that's normal or abnormal or bounding or faint. That's your one pulse that you've ever palpated. So a lot of what you're going to do as students is just keep palpating pulses, just keep examining patients, temperature gradient, like what's normal. It's just as important to examine patients who are normal and healthy as it is to examine patients who have peripheral arterial disease. So you have a frame of reference. So when I was a student, this was a system that we used, right? It was either full equal and regular, moderate equal and regular, weak equal and regular, or non-palpable. I've worked with vascular surgeons who don't go by any other scale other than it's either present or it's absent. And this is the scale that we use at the college, right? This is from Schwartz's textbook, the current textbook, which you should all have purchased. Right, so 2/4 is our normal. But again, it's very subjective. This is sort of like heart murmurs. Like your 2/6 would be my 1/6, etc. So this would be your 2/4 might be my 1/4, depending upon how much experience you have and how sensitive your tactile examination skills are. So suppose you're trying to find a very weak pulse. You're trying to find a very, very weak dorsalis pedis pulse in an elderly patient with suspected PAD. So what do you do? Like you intuitively, you grab the foot, you palpate the foot, and you exert a little bit more pressure trying to feel that pulse. But in doing so, you may actually be feeling your own pulse, and you're really not sure the very, very weak pulse if you're feeling the patient's pulse or the pulses in your fingers. So what's helpful sometimes is to actually palpate your own radial pulse, right? So in a very, very weak pulse, just to convince yourself you are palpating the patient's pulse, and now palpating your own pulse in your fingers, feeling your own pulsation in your own fingers, just sneak around and palpate your own radial pulse. And if they're synchronous, right? If the pulse that you're palpating, your radial pulse, is synchronous with the pulse that you're feeling in your fingers, you're not feeling the patient's pulse, you're feeling your own. Cross your hands. So for very, very subtle differences in temperature, sometimes it helps not only to palpate each foot, the toes of each foot with the right hand and the left hand, but to cross your hands. And sometimes that brings out the subtle temperature change in one foot versus the other. So that's what I do. I guess that's maybe one of my recommendations. Try that and see if it works. Be eclectic. We all have a lot of experience, or different levels of experience at the college, and there's more than one right way to do something. So take from all the clinicians and formulate your own eclectic approach. Well, here's a quick putting it all together video. So temperature gradient, I know it looks like I'm squeezing the toes, but I'm not, I'm just this gently. And if there's any question as to one limb being any more warmer or cooler than the other, just sort of cross your hands. You're doing your capillary return now on each one of the toes. You're looking to see how long it takes after they've blanched for the color to come back. Do that in each one of the toes. And now I'm going to do my posterior tibial pulse, which, by the way, sometimes it's very difficult to feel a posterior tibial pulse, especially in patients who have ankle edema, in which case you bring out the Doppler, which we'll get into in a second. Now, so if there's any question as to whether or not PAD exists, you can do other ancillary tests. One is called, various names, the elevation dependency color change test, also known as Berger's test, and that's where you place the patient supine, you raise the legs at about a 45-degree angle, and the student pointed out that coincidentally we have our peripheral arterial disease poster in the background over here. So you raise your legs, not your legs, but you raise the patient's legs 45 degrees, you have them wiggle their toes, and then you look at essentially to exsanguinate or to hasten the effect. And then you look at the color of the plantar aspect of one foot versus the other, and the toes of one foot versus the other. And then you slowly have the person sit up, dangle their feet off the exam chair, sit them up slowly so that they don't become orthostatically hypotensive. And then you look at the color. You look at the color of each foot for dependent rubor. You can see some residual metaductus for your people who are into orthopedics there. So Doppler examination is also something that's very, very useful. And I think I'm going to play a sound now. This is, I want you to be able to test these, and we're going to play the sound now, so the sound guy has to bring it up. It's either going to be monophasic, this is for you to listen to. So it's either going to be monophasic, biphasic, or triphasic Doppler sounds. And remember, when you use the Doppler, you want to angulate it about 45 degrees, right, to the long axis of the artery when you do so. And then you use sonicator gel, or so like ultrasound gel to close the air gap when you angle it. So here we go. Oh, and you point it in the direction of traffic, right? So let's say you were a highway patrolman and you're sitting there with a Doppler gun, right, shooting cars that are coming by you. right? You want to direct it into the flow of traffic. You want to direct it into the blood flow as opposed to the opposite direction. So I'll show you a slide about that in a second, but let's listen. Here we go. So monophasic, biphasic, or triphasic? I'll give you a hint. 1, 2, 3. 1, 2, 3, right? Okay, so let's listen to that again. So again, healthy young male patient, student actually, not a patient. 1, 2, 3. 1, 2, 3. So that's triphasic waveforms, right? So that's a very good waveforms. And as we mentioned, if you ever forget which direction to point your Doppler probe, point it into the direction of traffic. So like imagine you're the highway cop and you're shooting this red car. Imagine this is a red blood cell coming towards you, right? So you're shooting into the direction of traffic and angulating it at about 45 degrees. How many people have purchased blood pressure cuffs? So raise your hand, blood pressure cuffs. So everybody's dutifully purchased blood pressure cuffs because of the quote-unquote requirement of the physical assessment. And when you get downstairs, you're going to say, to the average student, do you have your blood pressure cuff? No, it's upstairs in my locker. No, it's home. And you don't have a you don't have a manual blood pressure cuff because everybody really relies on the automatic blood pressure machine to do the brachial, systolic, and diastolic. But bring it with you. Bring your stethoscope to every session of clinic and bring your manual, inflatable blood pressure cuff because we can do our own ankle brachial indexes down in the clinic. We have the Doppler. We've already done our blood pressure, so we have our systolic or brachial systolic reading, and all we have to do is just use the Doppler, which we have in the dispensary, and our inflatable cuff, and get our brachial ankle systolic and do the math. Ankle arm. They used to call it ankle arm index. Now they call it ABI or ankle brachial index, and then you can translate what you've gotten to sort of like this ABI range value, and if it's like greater than so like 1 to 1.4, it's normal, 0.9 to 0.99 borderline, et cetera, until you get all the way down to 0.4 after you've done the math, right? You're taking the ankle systolic and over the brachial systolic, and you get your number. So the usefulness of your manual cuff is yet to come. So 2 red herrings for you, and then we're done. Red herrings essentially are distractors, and it's 2 of the biggest distractors I think that I want to pass on to you. Many times, I say many times, but there are times that patients will come into you and they'll complain of an ingrown nail. I have an ingrown toenail, I have pain in my big toe or whatever toe it is, and it's from an ingrown toenail. And you hear, patient has an ingrown toenail, it must be an ingrown toenail. When all the time, what they're doing is they're rationalizing the pain and trying to assign a cause to it. When sometimes it's not an ingrown nail at all, but it's ischemic pain from PAD. And what sometimes you'll see, I mean, thank goodness it's rare, but I've seen it once or twice in the clinic. Dr. Treppel has seen it himself, and most of us clinicians have seen, is that a patient and I hesitate to say this, God forbid, that there are patients who have gone to outside doctors, and in an effort for the outside doctor to permanently alleviate this chronic ingrowing nail, they'll do a nail matrix phenolization. Now, to do a nail matrix phenolization on a patient with peripheral arterial disease, it never works well. And so that's one thing you have to promise me that you make sure that every patient who comes in, especially in those who you suspect of having PAD, that you rule out peripheral arterial disease as one of the etiologies of their pain. We see a lot of onychomycosis. We see a lot of onychodystrophy in our patients downstairs, and you have to wonder, is it onychomycosis or is it onychomycosis lookalike? In other words, onychodystrophy secondary to peripheral arterial disease. Probably the biggest word of advice I could give everybody here, all the students and prospective docs here, is it never hurts to order further vascular testing. The only consult you'll regret is the one that you didn't order. And a lot of people wait. They wait long and they expect things to get better on their own, but things rarely get better on their own. And you're going to reach a point where the time to intervene is lost, and then it becomes a salvage. So order your consults early. Don't be afraid to order a further vascular testing if you have a suspicion, if the gut feeling, the little voice inside of you says this doesn't look right, follow that voice. Every clinician has her or his own pearls. Draw from every clinician's unique experience. There's more than one right way to do something. You're in an institution with a lot of experienced clinicians. Draw from each one of their experiences and be eclectic. Thank you very much.